Okay, now we will continue on our ECG series and we will talk about T-wave today. So the T-wave, guys, is the positive deflection after each QRS complex. This is the general definition of the T-wave. And when we are talking about T-wave, it represents the ventricular repolarization, meaning that when the ventricle relaxes, this electricity that is generated because of this relaxation will be given us, will give the T wave. Now, as a general rule, the T wave should be upright in all leads, except for two leads, which are the AVR and V1. AVR and V1 are always, the T wave there will be negative. Okay, this is very important. Okay. And for the normal amplitude, the most important part of the T wave is the amplitude itself. So it should be less than 5 millimeters, meaning that 5 small squares, and limb leads. Limb leads meaning like AVR, AVF, AVL, lead 1, lead 2, lead 3. Okay, so it should be less than one large box. But in the precordial leads, V1, V2, V3, V4, V5, and V6, they should be less than 10 millimeters, okay, in precordial leads. Anything above that, we will say we have a peaked T wave. So peaked T wave, as we see here in this illustration, you can see it's 1, 2, 3, 4, 5, 6, 7, and almost 8 small squares in lead 2, meaning that this is hyperacute or peaked. Actually, we use peaked T wave. We use this term peak when it is narrow. Okay, narrow means it's less than 3 or 3 to 5 small squares. So this is narrow T wave and it's really tall. We say this is a peak T wave. And whenever you see a peak T wave, you have to think about hyperkalemia. Now, another example in which we have a peak T wave as well in this EKG here down, but we can see that the width of the T wave is really prolonged, right? In this case, we use another terminology. We can say we have a hyperacute T wave. And whenever you see a hyperacute T wave, you have to suspect an ST segment elevation. And this is seen with myocardial infarction, as you can see here. You almost always have to think about myocardial infarction and correct clinical settings. All right, let's talk more about some features of the T waves. T wave should be negative in V1. We say this is very important. V1 and AVR, they should be negative. Now, let's focus on V1. Almost always you have to think, when you have to look to V1, and it should look like this. It should be a negative deflection. Now, if it is positive in V1, first you have to rule out leads misplacement. You have to make sure that the nurse or the practitioner has attached all the leads correctly. If they are attached correctly, you have to think about two important possibilities if it is positive. The first one, it's coronary artery disease. If it is positive, you have to think that this patient has a coronary artery disease, regardless of what type of coronary artery disease, maybe stable angina, unstable angina, myocardial infarction, anything. Number two, if it is positive and is a new finding that the patient didn't have it in the prior EKGs, you have to think about acute ACS, acute coronary syndrome. So if it is positive and the wave is in U, you have to think about acute ischemia, just like this EKG. This is also V1. And you can see here it is positive. If this is a chronic thing that the patient has for like the past 5 months, you have to think about coronary artery disease. But if this is something new, you have to think about acute ischemia. All right, now let's talk about the T-wave inversion. One important information, guys, that T-wave inversion in lead 3 is a normal variant. Some people have this as a normal phenomenon. So don't look at lead 3 to determine we have a T-wave inversion or not. The most important part, any new T-wave inversion is always abnormal. So if the patient has an EKG that the T-waves was normal, and a subsequent EKG done, let's say 5 days after that, that show the new T-wave inversion, this is abnormal, and you should investigate for that. What are the causes that we should think about? First, it is normally seen in children. Okay, again, because in children, the right ventricle is much enlarged, it's much prominent, so the electricity will be in opposite direction from the adult electricity. Okay, so normally in adults, the T-wave should be positive, right? But in children, the electricity is in the opposite direction because, again, in the adults, the left ventricle is much prominent, it's much enlarged, much powerful, so it generates more electricity. And normally, electricity from the left ventricle will give us a positive T-wave. In children, the opposite happens. In children, the right ventricle is much enlarged because of the normal physiology of fetal circulation. So the electricity will be coming from the right ventricle more, and it will be the opposite direction of the adults. So it will be a negative direction. So if you see T-wave inversions in children, this is a normal thing. Number two is myocardial infarction and ischemia. And to say that this T-wave inversion indicates a myocardial infarction or ischemia, it should be in a contiguous leads, meaning that, for example, if I have an EKG showing T-wave inversion in lead 2, 3, and AVF, I have to highly suspect an ischemia or myocardial infarction inferior wall of the heart. Okay, so T-wave inversion, if they are in contiguous leads, you have to think about myocardial infarction, ischemia. Number three is hypertrophy. Hypertrophic cardiomyopathy is a really very common cause to have T-wave inversion. Again, because the muscle bulk is not normal. Moreover, is PE, pulmonary embolism, in which the right heart will have a hard time pushing blood to the lungs, so it will generate more electricity, so it will be opposite to the normal adult. Bundle branch block, either left bundle or right bundle, will give us T-wave inversion, and increased intracranial pressure as well in patients with a trauma or subarachnoid hemorrhage. They will have diffuse, bizarre T-wave inversion all over the EKG. This is a good example here, guys. If you look at the T-wave, let me use this. Okay, we can see this is lead 2. We have T-wave inversion here, T-wave inversion 3, and T-wave inversion AVF. And because they are in contagious leads, we have to think about ischemia, right? So this patient either has, most likely it will be a non-STEMI because there is no ST segment elevation. So it will be non-ST segment elevation. We will talk about type of ischemia in later videos. Okay. Now, another important variation of the T-wave is the biphasic T-wave, in which there is two parts of the T-wave, one of positive and the other is negative. And you have to think about two common etiologies, either ischemia or hypokalemia. So anytime you see a biphasic T-wave, you have to think about either ischemia or hypokalemia. In ischemia, the T-wave will be up, first positive deflection, and after that negative deflection, up and down. And I usually remember it by IUD. IUD is a common abbreviation used for intrauterine device, but we can use it here. Ischemia, up, then down. Ischemia, up and down. But in hypokalemia, it is the opposite. In hypokalemia, it will be down first and after that up. So HDU as well, you can just remember. Okay, an example of that, look here. This is V3, okay? We have a down and then an up. If we see this, we have to think about hypokalemia. Okay, but if in this EKG here, we have an up and after that a down. And you can see the ST segment itself is elevated. So this is highly specific for ischemia, okay? Up and down. Ischemia, up and down, IUD. You have to remember this. Okay. This is really very important because sometimes the EKG could only have a T-wave abnormality. So they will indicate something you have to think about it. All right, and that's it for T-waves. This is really very important. And we'll see you in next video.